Yes. Good morning, everybody. Welcome to the class. All right. Yes, please type your names. Thank you. All right, so we can start the class. So this class, because of the spread of influenza in Kish Island, we are doing it online, and I'm using this YouTube platform to do the class. Everything will be saved, and you will have automatically um, saved videos after the class. You will have access to those videos. And in case you get disconnected, don't worry. You can watch the video afterwards on the same channel. All right. In the name of God, what we are going to do today is to talk about mechanism and classification of hypersensitivities. I'm Dr. NoorBioScience, professor of immunology at Department of Immunology at Tom's. And basically, the classes I'm going to teach you today and tomorrow, 17th and 18th of December, are mechanism and classification of hypersensitivities, immunology of infectious diseases, and also immunodeficiency. So today we are going to start with the mechanism and classification of hypersensitivity. We will start the class right now. It will be almost uh, basically, I think 60, yeah, 70 minutes roughly. And then you will have a break and we start the next class at 10 o'clock. That would be immunology of infectious diseases. So I want to start this class by pointing out the importance of models in reality. I had an introductory class with you guys, and if you recall, we talked about scientific models and their importance in education, in learning, and also in predicting and analyzing the behavior of complex biological systems. Reality is complex, and we use models as simplified representations of reality. This is important for the class that we're going to have today, and also the class that we're going to have tomorrow. So we have different types of models. Models are basically very simple simulations or very simple representations of reality. They can be physical models like the model of the heart that I'm showing you in here, or the model of the solar system. They can be conceptual models like these models of atom that I'm showing you in here. And in case of physical models, you build something physically, but in case of conceptual models, you don't build something physically. You draw something, you draw the concept that you have in your mind on a piece of paper. And in the case of mathematical models, you try to describe the behavior of the system using mathematical equations. And basically, all of the science of physics, the whole of physics, are mathematical models, like the second law of Newton or law of gravitation, or other models that we have for describing the activity of electromagnetic fields, and so on and so forth. So we do have a simplified model of the immune system that we usually use in these classes. But one thing that we should keep in mind is that models are only approximations of reality. They are not equal to reality. So this is the model of the immune system that we usually use for training of immunology. And basically, it shows us that immune system has two major parts or two major arms: innate immune system and adaptive immune system. Innate immune system itself is composed of physical chemical barriers as well as some cells which usually perform phagocytosis. An adaptive immune system comprises B cells and T cells, and B cells generate the type of immune response which we call it humoral immune response. So it's present in body fluids, but T cells generate the type of immune response which is named cellular immune response or cell mediated immunity. So this is the model that we have for the structure of the immune system, or a simplified representation of the structure of the immune system. We also have a model for the function of the immune system. That is the self, non self, safe, non safe model. And basically, what it shows us is that we have self entities which are harmless, and they are located in here, like a lot of different molecules that we have in our own cells. We also have infectious agents. We also have infectious agents, which are located down here, different viruses, bacteria, fungi that cause disease. But we also have neoplastic or injured cells up in here. These are self entities, but they're dangerous, they're non safe. And we have a lot of different things down here: microbial flora, food antigens, pollens, and a lot of different things which are foreign to our body. So they are considered non self, but they are safe at the same time. So this is a simplified model of the function of the immune system. And basically, we say that on the right side of the page, when we're dealing with a non-safe entity, regardless of whether it's self or non-self, we should have an immune response. And when we are dealing with something which is safe, regardless of whether it's self or non-self, we should have something named tolerance, lack of immune response, which is basically a supportive lack of immune response. So this is a simplified model of the function of the immune system. So, how immunological diseases happen? Well, when things get mixed up, like infectious agents are mistakenly considered safe, we have infectious diseases. When neoplastic cells are mistakenly considered self, we have cancers. When autologous molecules, which are harmless, are mistakenly considered dangerous, we have autoimmune diseases. And also, when we have microbial flora, food antigens, or pollens considered non-safe. We have some other diseases which some people call them hypersensitivity. So the topic of this class, as I mentioned, is hypersensitivities. We have different subfields of immunology here. We have infectious disease immunology that deals with infectious agents, immune response against infectious agents. We have cancers up there. We have autoimmune diseases in here. And here, as I mentioned, we have a group of diseases which are named hypersensitivities. So in this definition, hypersensitivity is basically referred to pathological immune response against foreign entities which are safe. So this is one definition of hypersensitivity. However, hypersensitivity has also a broader meaning. The broader meaning for hypersensitivity is any type of unwanted immune response that causes damage. This is hypersensitivity in the broader sense. This is hypersensitivity in a generalized form. Any type of unwanted immune response that causes damage. So if I look at here, hypersensitivities are limited to immune response against non-self entities which are safe. So this qualifies as an unwanted damaging immune response. But we can also have unwanted damaging immune response up in here. And even for infectious diseases, we can have unwanted damaging immune response. So in the broad sense of the term, here, if you get immune response, it's called hypersensitivity, immune response against microbial flora, food antigens, and pollens. We get hypersensitivity. But we also have hypersensitivity up in here. If you have an autoimmune disease, it does qualify as an unwanted damaging immune response. So these ones can also be considered hypersensitivity. Can we have unwanted damaging immune response against infectious agents? Well, infectious agents, we do require protective immune response against them. So immune response against an infectious agent is something which is desirable. But if the immune response against the infectious agent is too strong so that it causes tissue damage, it does qualify as an unwanted immune response, which is damaging. And then we can also consider this as hypersensitivity. So we have hypersensitivity here, we have hypersensitivity here, and we have hypersensitivity here. So this is the first thing that I wanted to teach you today, that hypersensitivity in the narrow sense of the term only refers to immune response against things which are down here, the ones that are located on the safe non-self side. But in the broader sense of the term, you can have hypersensitivity here. We can have hypersensitivity here when we have an autoimmune response against our own antigens. And we can have hypersensitivity against infectious agents when the immune response is too strong and it causes damage. So in this class, and the majority of the classes that you will have in this course or you had in the past, we are using the broad sense of hypersensitivity. And basically, we can say that we can have three types, three classes of hypersensitivity. I'm trying not to use the word type because I'm going to use the word type for hypersensitivity to refer to different mechanisms of hypersensitivity. So we can have three classes of hypersensitivities. All right. So by keeping this in mind, we have four types of hypersensitivity. The type is different from what I mentioned before. The type is highlighting the molecule or molecules which are involved in the generation of hypersensitivity. Sometimes hypersensitivity is generated by IgE molecules, which are a type of antibody. These hypersensitivities are called type 1. Sometimes hypersensitivities are caused by antibodies other than IgE, mostly IgM and IgG. These are called antibody-mediated hypersensitivity or type 2. Sometimes hypersensitivities are caused by immune complexes. What is immune complex? When you have an antigen and antibody bound to each other, then you have an immune complex. So sometimes hypersensitivities are caused by antigen antibody complexes or immune complexes, and these are called type 3 hypersensitivity. So type 1, 2, and 3 are all somehow related to humoral immunity, related to antibodies, which are produced by B cells. But type 4 is caused by T lymphocytes. It's caused by elements which are responsible for the generation of cell-mediated immunity. So putting these two classifications of hypersensitivity, if I go back to this previous slide, I can say that we have three groups of hypersensitivities based on the molecules which are targeted by our immune system. And we have four types of hypersensitivity based on which molecules are mediating that, which molecules from our immune system are causing the hypersensitivity. And we're going to basically classify the examples that I'm giving you based on those three groups and these four classes. All right. So I'm going to start from type 1 hypersensitivity. Type 1 hypersensitivity is also known as allergy or allergic reactions. These are hypersensitivities which are mediated by IgE. And as I will show you in the later slides, you will see that this is a type of hypersensitivity which happens relatively fast. So we also call it immediate hypersensitivity, because if someone possesses the IgE molecules against a specific type of antigen, which here we call it allergen, the process of hypersensitivity takes place very fast. So from previous classes, you're familiar with different functions of antibodies. Here I have a B lymphocyte, and here are antibodies which are produced by that B lymphocyte. And these antibodies can have a variety of functions. They can neutralize their targets in the mucosal surface. So if you have something at the surface of mucosa, like a bacterium or maybe a virus, some antibodies can be secreted into the mucosa and bind the target and neutralize it. Neutralization means that they sort of make the target incapable of performing its function. Then we have neutralization in serum. We have neutralization in serum. So some antibodies are present in serum and they can bind to their target, neutralizing it. Some antibodies facilitate phagocytosis. It's called opsonization. Some antibodies activate complement, which are protein molecules in plasma, which can perform protective functions. Some antibodies are basically activating what is called antibody-dependent cytotoxicity, and some antibodies are eosinophil and mast cell activators. They cause eosinophil and mast cell degranulation. And by the way, I know that this basically webcam is covering part of the left side of the slides. I cannot get rid of it even if I turn off the webcam. So if you don't see something on the right lower side, I will explain it for you. So we have different classes of antibodies performing different functions. IgA is the most important type of secretory antibody. It's secreted into mucosal secretions and neutralizes targets there. IgE is on the right side. It's an eosinophil and mast cell activator. IgM is a complement activator and to some extent a neutralizer, but IgG is the multifunctional antibody that we have. It can neutralize very well. It can opsonize very well. It can also activate complement or activate antibody-dependent cytotoxicity. So what we have in here that it might cause some problems labeled as type 1 hypersensitivity is the IgE class of antibodies. So here I have the scenario where IgE is produced. So good IgEs are IgEs which protect us against the worms. So here I have a schematic representation of a worm. So worms cannot be neutralized, they cannot be opsonized, they cannot be killed by complement. So the way that things work is that when you have a worm in the body, especially inside tissues, its antigens are phagocytosed by macrophages and dendritic cells. They present it to T cells. T cells become T helper 2 cells. They produce IL-4, and IL-4 tells B cells to produce IgE. And IgE goes and covers the surface of the worm. So we have two types of cells, eosinophils and mast cells, which can bind to IgE molecules. And eosinophils, when they receive a second cytokine named interleukin 5, they would release their toxic granules These granules that you have in eosinophils, they are called helminthicide. Helminthicide means worm killer, and they release these worm killer granules, and through that you have the basically destruction of the cuticle and basically the uh, different proteins of the worm, and the worm dies. So this is defense against helminths. As you're seeing in here, we also have mast cells. Mast cells have granules which contain a variety of things, including histamine. Histamine is not a worm killer by itself, but it does have some functions which would facilitate the removal of the helminths, especially helminths which are located inside gastrointestinal tract. So we kind of have sharing of responsibilities, or the division of responsibilities here between eosinophils and mast cells. If you have a worm which is inside tissues, it's more important for the eosinophils to get activated and get rid of the worm. But if you have a worm which is inside gastrointestinal tract, which is the case for a lot of helminths, then the function of mast cells would be more important. Because if a worm is inside the lumen of the gastrointestinal tract, secretions from eosinophils might not reach there. So mast cells will accumulate under the mucosa, and they release their granules, and these granules will increase the motility of the gastrointestinal system because they can make the smooth muscles contract. They also stimulate the secretion of mucosa, which in itself can lead to basically removal of the worm. They can make it harder for the worm to bind to the surface of mucosa, and also they increase the flow of blood. They increase basically the blood flow, and that might also lead to the removal of the worm through increase in mucosal secretion. So these two cells in here have different functions that would help us perform an effective defense against helminths. So this is the good part of the story, or these are good IgEs, which are protective. However, in some cases, IgEs are produced against entities which do not require IgE for protection. They don't need any protection at all. So in this picture, you see two things which might lead to erroneous production of IgE. One of them basically is these pollens that you're seeing in here, and the other one, this honeybee, is basically the antigens and the proteins which are existent in its venom. So if you get a bee sting, they will be introduced to your body, and then immune system might mistakenly react against them. So if you have, imagine that these are some molecules, either small molecules or protein molecules, which are derived from pollens or maybe a bee sting. Sometimes IgE is produced against them. Why? Well, we don't know exactly why some people's immune system produces IgE against things like pollens or proteins in the bee venom or some other proteins that I will show you in the later slides. It appears that it's a miscalculation from the immune system. So it miscalculates, calculates things in an erroneous fashion, and basically starts producing IgE. So IgE binds to these molecules. And then what happens is similar to what happened before. Eosinophils and mast cells would appear, and then eosinophils and mast cells would release their granules. And these granules that are released here, they do not perform any good function. They do not perform any protective function, because basically we don't need any protection against things like pollens, for instance. And this is the mechanism by which we have a type of unwanted damaging immune response, unwanted damaging immune response. And that unwanted damaging response, as I mentioned in previous slides, is labeled hypersensitivity. So what are the results of this mast cell and eosinophil degranulation? This shows a picture of mast cells releasing their granules. So what happens there? Well, if I want to show it in more detail, IgE binds to the receptors at the surface of the mast cell. So IgE bound to the pollens, also binds to the receptors at the surface of the mast cell. So imagine that these are allergenic molecules and they release their granules. So I'm only showing you mast cell in here because their role in hypersensitivity type 1 is kind of more important, but eosinophils also contribute to the process. What kind of things exist in here? Well, we have histamine, we have things named lipid mediators, and we have cytokines. And together they lead to a variety of changes in tissues. One of the things which happens is vasodilation. Vasodilation, it means that blood vessels will dilate and the blood flow to that region will be increased. So this is called vasodilation. The second thing which happens as a result of the function of histamine and the rest of the things that we have in here is increase in vascular permeability. So the endothelial cells that uh, generate the vessels, the blood vessels, they increase basically the permeability, the possibility of molecules to leave the blood vessels. And this leads to some part of the plasma leaving blood vessels and some other molecules leaving blood vessels. We also have contraction of smooth muscles, which is important in the gastrointestinal tract and also in the respiratory tract when we have a lot of smooth muscles. And we have some other processes which I have labeled inflammation, which is a complex set of interactions which happens between cells and molecules and tissues. So, as considering that we have increase in blood flow, increase in permeability, and a smooth muscle contraction, we have different manifestations. So here I have a table that I want to show you how immediate type hypersensitivity or type 1 hypersensitivity manifests at the clinical level. So here I have the target organ, the name of the process, the allergens which lead to the process of which cause hypersensitivity, how that allergen enters the body, and what do we see at the clinical level. So here I have vasculature, skin, upper respiratory tract, lower respiratory tract, and GI tract. And I want to show you what happens if we have hypersensitivity in a systemic level or in the skin or upper part of respiratory system, lower part, or the gastrointestinal tract. So let's start from here. Sometimes the allergens are introduced in a systemic fashion. They enter our body through basically veins in an intravenous fashion. How can this happen? Well, one of the most common examples is when a person receives a drug in an intravenous manner, like intravenous injection of penicillin, for example, is one example. Sometimes it's not a drug, but an arthropods or an insect's venom. So when you get stung by a bee, for instance, sometimes if the amount of the venom which is injected is too much, part of it might enter veins and through the blood circulation, it will spread all over the body. And sometimes we might use serum which is derived from other people or maybe from an animal uh, as a medication in order to treat or prevent some diseases from happening. I will mention this later. So if they enter our blood circulation, they will go everywhere. And if we have formed IgE against some elements like the drug elements or proteins in the venom or proteins in the serum, we have the mast cell degranulation and eosinophil activation all over the body. So if you recall from previous slide, the elements which are released from granules in mast cells like histamine and lipid mediators and cytokines, they can lead to vasodilation. They can lead to increase in vascular permeability, and they can also lead to contraction of smooth muscles. So we can have edema all over the body due to increase in blood flow and increase in vascular permeability. The fluid part of the body can leave the vessels and it will lead to edema. We can have contractions in different parts of our respiratory system. And if it happens in the trachea, it will be very bad. It might lead to tracheal occlusion. And due to systemic vasodilation and the leakage of the fluid part of the blood from our blood vessels, We might have a decrease in blood pressure, leading to what is called a circulatory collapse. So the second one, the tracheal occlusion, and the third one, the circulatory collapse, are life threatening. They are life threatening. So this is the most dangerous form of allergy. It's called systemic anaphylaxis. It's called systemic anaphylaxis. And this is the type of allergic reaction which can be deadly. It can lead to basically decrease in blood pressure in such a way that the person loses its ability to uh, basically uh, provide sufficient circulation for different tissues, including the nervous system. And sometimes it might lead to choking if it's severe tracheal occlusion. So systemic anaphylaxis then is when you have the system-wide or systemic spread of allergens, usually drugs, phenol, or maybe some other molecules, through blood circulation. It's associated with the generalized edema, tracheal occlusion, and circulatory collapse, and it could be deadly. The other types of hypersensitivity are not as dangerous. So if the hypersensitivity type 1 is limited to skin, like in case of a skin bites, insect bites, those insect bites that do not introduce too much poison, too much venom, so that it can get spread through blood circulation in cases that the tiny amount of venom is injected so that it's only localized, it's a localized spread of the venom. Or in cases that we use allergens for testing, as I will show you in later slides, then you have basically a limited reaction. In these cases, you don't have intravenous or basically systemic spread of the allergen. You have a tiny subcutaneous injection. And well, the symptoms that you will get and the signs that you will get are localized. Localized increase in blood flow, localized increase in permeability, and what is called the Wieland flare. Wieland flare, it means that you have a little bump and you have a little redness in the skin, and it's basically a skin allergy. It's a skin allergy. So it's much more localized and basically less dangerous compared to systemic anaphylaxis. If you have things like pollens or dust, or sometimes basically some derivatives from tiny arthropods, which are called mites, which are inhaled, and they are restricted to the upper part of the respiratory system, so to the nose, nasal cavity, and pharyngeal area, and upper parts of trachea. Then you have edema or production of extreme mucosa in the upper parts of the respiratory system. And we have something named allergic rhinitis. So the person will get a runny nose, a lot of secretions, maybe some itching, and basically the symptoms are limited to what we call upper respiratory system. So this is another common manifestation of type 1 hypersensitivity, but it's basically only annoying, so it's not usually posing any risk to the patient's life. If the same things like pollens, dust, or derivatives from mites are inhaled and they reach the lower parts of the respiratory system, which sometimes happens, and the lower parts, we mean bronchi, bronchi, and bronchioles, then we can have a smooth muscle contraction in the bronchi and bronchioles. So it's called bronchial constriction. And at the same time, you might have inflammation in the airways. And this might be a little more serious. It's called bronchial asthma or allergic asthma. So this is a more serious manifestation of the respiratory allergies. So the upper part is just allergic rhinitis, but the lower part, it can be bronchial asthma, and then the patient might present with difficulty in breathing. It's called dyspnea. And finally, if you have antigens like milk antigens, egg antigens, or some other antigens from wheat or fish, which are entering our body through oral routes, then mast cell degranulation might happen in the gastrointestinal system. And you might not be seeing this, but it will lead to vomiting and diarrhea, and also skin manifestations like urticaria. So this is called food allergy. So here in this table, I'm showing you five different types of, uh, basically five different types of IgE-mediated allergic reactions. The most severe form is the systemic anaphylaxis, which is associated with intravenous spread of allergens leading to circulatory collapse and possibly tracheal occlusion and widespread edema. So this is the most serious form. The second form was localized skin allergy. The third form was the allergy in the respiratory system, but the upper part of the respiratory system. In the case of allergic rhinitis, you don't have difficulty in breathing. It will be just a runny nose and increased secretions, nasal secretions. But in the lower part of the respiratory tract, we have bronchial asthma, which can lead to dyspnea, which can lead to basically difficulty in breathing due to bronchial constriction. And finally, we have food allergies. We have food allergies. So I'm going to show you some pictures of these manifestations. This is what is called urticaria or hives. So as you're seeing in here, you have redness, and well, you might not see it very well in here, but you do have some basically bumps on the skin, and this is due to increased vascular permeability and due to increased flow of blood, increased blood flow. So you have redness and you have some tiny bumps in here. This is called urticaria. Urticaria is usually a representation or a manifestation of food allergies, even though the food allergens enter through gastrointestinal tract, but they can lead to skin manifestations. That's one thing that you need to keep in mind. And I have the slide for it in Arabic because I was teaching this the same topic in the Karbala branch of the university. So this is basically the Arabic word for it. Sometimes the urticaria can be generalized, it can be all over the body, which is a manifestation of food allergies. This is an example of allergic response to bee venom. So bee venom in itself is not very dangerous. If you get stung by a bee, it will be a little painful, but it's not something that can cause serious problem for you. But for people who have IgE or who can produce high levels of IgE against antigens of the bee venom, then if they get stung by a bee, they can have more severe consequences, like the edema that you're seeing in the eye, or in case of anaphylaxis, it can be basically more severe manifestations. These are two examples of anaphylaxis for people who've developed hypersensitivity to uh, systemically spread allergens. So as you're seeing in here, you have the edema in the face. Here you have edema in the face, in the eye region, or in even the basically lips of the person. So if the same edema takes place, if the same edema together with muscle contraction happens in the tracheal region, you might have tracheal occlusion. And this is an element of anaphylaxis. Basically, anaphylaxis is dangerous for one of these two reasons, either the problem in the respirating, problem in breathing, or the circulatory collapse. So if a person shows up with this type of allergies, how do we find out about the specific type of allergen which is causing it? Well, we use what is called a skin test or a skin prick test. So the way that we try to identify the type of molecule or the type of the allergen which is causing the problem is that you extract a little bit, basically prepare extractions, you prepare little, uh, basically tiny bits of the antigens in a fluid, in a aqueous medium, and you put it on the skin, and then using a tiny needle you make a little bit of that antigenic extract enter the skin. So that's why it's called pricking. It means using tiny needles to drive a little bit of that antigen into the skin, and then you wait for 20 minutes to 30 minutes. So if the person has formed IgEs against any one of these allergens, after 20 to 30 minutes, you see a little bump in here together with the redness. So in case of this particular test, if you can see, you have a little bump in here for the allergen number 1. For allergen number 2 and 3, we don't see anything. For number 4, we also see a bump. And for the ones down here, we don't see any bumps. So this is how we test the person for allergens. And this is a basically a better picture showing many more different types of allergens. So one, two, three, four, all the way to the end. So you have different extracts of these allergens in an aqueous medium, and then you put it on the skin, and using a tiny needle, you drive a little bit of the antigen inside the skin, and then you wait for 20 to 30 minutes to see if there is any response. So we don't know exactly why some people generate IgE against these allergens. Apparently, as I mentioned, it's miscalculation of the immune system. So there are genetic factors involved, but there might be other factors involved in the process that are not very well known. And if a person is allergic to a particular entity, well, they should avoid being exposed to that allergen. If it's food allergy, we usually try to remove that allergen from the food, or recommend the person to use a diet which does not have that kind of allergy. If it's an allergic response in the respiratory system, again, we might advise the patient to avoid being present uh, basically in the environments where the allergen exists, or we might give them basically prophylactic treatments. So it's not part of our class, but prevention and treatment of allergies is an important part of what we call allergology, basically. All right. So this is what I mentioned about type 1 hypersensitivity. Type 1 hypersensitivity is down here. And as I mentioned, we can have hypersensitivity against things which are located in here, against autoantigens, against infectious agents. But for type 1 hypersensitivity, we don't have any autoimmune process, or we don't have any too strong or very strong immune response against infectious agents. Type 1 hypersensitivities are limited to safe entities which are non-self. So let's move on to type 2 hypersensitivity. Type 2 hypersensitivity is also caused by antibodies, but antibodies other than IgE. So if I go back to this slide, IgE was the one that is responsible for type 1, but IgM and IgG are the ones which underlie type 2 hypersensitivity. So if I want to show you type 2 hypersensitivity could be here against safe entities which are non-self. They can also be against our own molecules, and they can also happen against infectious agents. So unlike type 1 hypersensitivity, which was limited to the lower left quadrant, for type 2 hypersensitivity, sometimes we have that unwanted damaging immune response against microbial flora, or maybe against food or other things. Sometimes it's against our own molecules, so it qualifies as an autoimmune response, or it can be against infectious agents. So I want to show you examples for each one of them. So can type 2 hypersensitivity be against foreign harmless antigens, non-self antigens which are safe? We're going to start from this one. Well, I'm going to show you an example of type 2 hypersensitivity which is against a harmless foreign entity. We have a group of drugs which can be absorbed to the surface of red blood cells. So in this part of the picture, in this one, I have a red blood cell, and these tiny spikes that you're seeing are drug molecules which have been bound to the surface of the red blood cell. So drugs, as we know, these are foreign entities, but they are harmless. But in some cases, immune system starts producing antibodies against them. So if an antibody is produced against the drug molecule which is bound to the surface of the RBC, after the binding of the antibody, the RBC will be damaged, and it will qualify as an unwanted damaging type of immune response. Please note that the antibodies in this case are not produced against the RBC itself. They are not against the antigens of the red blood cell itself. They are against these drug molecules. But because the drug molecule is bound to the surface of the RBC, the red blood cell will be damaged. How would that damage happen if I have antibodies against this drug molecule bond to the surface of the RBC? Well, we have two sets of mechanisms which can damage a cell to which an antibody has bound. One is that complement will get activated. So if complement gets activated at the surface of the RBC, we will have something named membrane attack complex, and it will lead to the lysis of the RBC. Similar to what could happen for a bacterial cell if complement gets activated at the surface of the bacterium. And the other thing which might happen is that we have some cells, macrophages especially, that have receptors for antibodies, and they will perform phagocytosis. They will perform phagocytosis. So RBCs will be phagocytosed. And if you have too many RBCs getting phagocytosed or lysed through complement, we have something named hemolysis. And it might remove so many of our RBCs that we might develop anemia. Anemia means lack of sufficient amount of blood in the body. So, and we have hemolytic anemia. This is called DIHA, drug-induced hemolytic anemia. So in drug-induced hemolytic anemia, you have an unwanted immune response against drug molecules, but because these drug molecules have been previously bound to the surface of the RBC, red blood cell, the red blood cell will be damaged, and we can develop what is called hemolysis, and if it's too severe, it will lead to anemia. So drug-induced hemolytic anemia is an example of type 2 hypersensitivity, which is directed against a foreign entity which is safe, drug molecules in this case. So these are mechanisms by which red blood cells will be damaged. This is an example of type 2 hypersensitivity against non-self-safe antigens. How about non-safe antigens? Well, things which are non-self and they are non-safe, well, these are microbes, these are infectious agents. These are infectious agents that we do require a sufficient or basically a suitable immune response against them. But if the immune response against an infectious agent gets too strong, or if an immune response against an infectious agent goes and targets something else, then we might have hypersensitivity. So here I have a picture of the physical examination of a 12-year-old girl which has been referred to a clinic by sore throat, headache, fever, and pharyngeal exudates. So this is an example of sore throat or pharyngitis, to use the technical term. Sore throats or pharyngitis can be due to viruses. It's called viral pharyngitis, or it can be due to bacterial pharyngitis. So if it's a viral pharyngitis, we usually don't need a particular we don't need a special treatment. It's basically symptomatic treatment, controlling fever or some other symptoms like basically mucosal symptoms of mucosal irritations. We use antihistamines and things like that. But if it's a bacterial pharyngitis, we need to treat them with antibiotics. So how can we differentiate between a viral pharyngitis or a bacterial pharyngitis? Well, there are several things which help us. One is the fever. If the fever is more than 38.5, it's more likely for the person to have bacterial pharyngitis. The other thing is pharyngeal exudates. So if you look at the pharyngeal region in a physical exam, in a lot of cases of bacterial pharyngitis, you have these exudates, this whitish stuff that you're seeing in here. So this usually happens more often in the case of bacterial pharyngitis. So bacterial pharyngitis has an unwanted side effect, which is called rheumatic fever. It's called rheumatic fever. What happens here is that our immune system starts producing antibodies against these bacterial antigens. The bacteria which cause pharyngitis are usually streptococci. So our immune system will start producing antibodies against the streptococcal antigens in order to fight against them. So this is the good part of the story. But the bad part of the story is that some of those antibodies which have been produced against the streptococci, they can also bind to some antigens in the heart. So streptococci have a protein named M protein, and antibodies are usually directed against M protein. So in our hearts, especially in the endocardial layer, in heart valves and in endocardium, we have an antigen which looks like the M protein. So antibodies will mistakenly bind to that antigen, and they can lead to inflammation in the heart. They can lead to problems in heart valves, what is called basically valvular heart disease. And the same antibodies can also bind to some antigens in joints. And you can have a person which has had sore throat a few weeks ago, or maybe even a couple of months ago, and then the person is developing fever again with some joint pain or arthralgia, and at the same time some heart problems. And this is called rheumatic fever. Rheumatic, referring to the basically the joint symptoms, the part of the symptoms which are basically related to the musculoskeletal system. That is why we use the word rheumatic. But the more serious part of what is called rheumatic fever is the inflammation in the heart. It's called carditis, and it can involve the endocardium or myocardium or pericardium. But the involvement of the endocardium, which also generates the heart valves, is more serious. So it's an example of type 2 hypersensitivity. It's a hypersensitivity because it's an unwanted damaging response. It's type 2 because it's caused by antibodies IgM and IgG. And it's an example of hypersensitivity against the pathogenic microbe. So the microbe which is basically causing this process is a streptococcus, but the antibodies against the streptococci are targeting our own tissues. So in that way, it will basically be qualified as an unwanted damaging immune response against our own antigens. Can we have autoimmune processes which are type 2 hypersensitivity, antibodies which are directed against our own antigens? Well, in the previous case, the antibodies were against the streptococci, but they could mistakenly bind to our own antigens. So we usually do not call acute rheumatic fever an autoimmune disease, even though our own tissues are damaged. At least it's not a classical autoimmune disease, because the start of the process has been by an infectious agent. And by the way, this process is called molecular mimicry. Molecular mimicry, it means similarity between molecules, similarity between our own molecules or our own antigens with a streptococcal or a bacterial or infectious agents antigens. It's called a molecular mimicry. So acute rheumatic fever, it's not a classical autoimmune disease, even though our own tissues are damaged. But can we have type 2 hypersensitivity, which basically is part of a classical autoimmune disease? Can we have that? Well, yes. Here I have an example of red blood cells being damaged by antibodies against red blood cell antigens. So in a couple of slides before, I showed you an example of hemolysis, which was caused by a drug. It was called drug-induced hemolytic anemia. In that case, antibodies were generated against the drug. But because that drug was bound to the surface of red blood cells would be basically lysed as a consequence of complement activation or phagocytosis. In the case of autoimmune hemolytic anemia, you don't have any drugs involved. In this case, antibodies are produced against antigens at the surface of the red blood cells. Red blood cells antigens, basically antigens that belong to the red blood cells, and we have hemolytic anemia. So I use these two examples next to each other so that we can differentiate between them. They are both type 2 hypersensitivity. One of them is against a drug at the surface of the red blood cell, and another one is an autoimmune process. It's against antigens at the surface of red blood cells, antigens that belong to red blood cells. Here I have another example of type 2 hypersensitivity. We have a disease named myasthenia gravis. Myasthenia means muscle weakness, and gravis means severe. In some cases, antibodies are produced against what is called acetylcholine receptor. So in order for us to contract our muscles and to move our body, acetylcholine needs to be released from nerve endings in the muscles. So this is a nerve ending. These are synaptic vesicles, and they contain what is called acetylcholine. Acetylcholine has receptors at the surface of muscles. So when acetylcholine is released, when I want to move my arms or hands or any part of my body, signals are sent from the central nervous system to the motor nerves, and the signal reaches the end of the motor nerve where these synaptic vesicles exist. Acetylcholine is released, it binds to the receptors at the surface of the muscle, and then the muscle contracts. So this is the process that happens every moment in our lives. So sometimes antibodies are mistakenly produced against acetylcholine receptors, the receptors for acetylcholine. And if that happens, they will interfere with the binding process and they will also destroy these receptors. If I do not have sufficient levels of acetylcholine receptors, or if some of the acetylcholine receptors in my muscles are destroyed, then I cannot contract my muscles easily. And something happens which is called myasthenia. And it usually starts with the dropping of the eyelid, so the person cannot open its eyelids easily. And then weakness in the muscle happens in other parts of the body. So this is another example of a type 2 hypersensitivity, a type 2 hypersensitivity, which is a type of autoimmune disease. So I gave you two examples: type 2 hypersensitivity against red blood cells, type 2 hypersensitivity against acetylcholine receptors. And we have other examples as well. So let's move on to type 3 hypersensitivity. Antibodies are also present in type 3 hypersensitivity, but not alone, together with antigens. So when antibodies bind to antigens, we have something named immune complex. You know that most of the antibodies, especially IgM and IgG, have more than one arm to bind the target antigen. And a lot of antigens have more than one epitope to bind to antibodies. So this having more than one region to bind to the antigen, and for antigens having more than one epitope to bind to the antibodies, sometimes leads to big complexes of antigens and antibodies. And these are called immune complexes. Immune complexes. So if these things are produced in the body, they should be cleared quickly. And usually our macrophages take care of them. So if you have big immune complexes, especially in the blood, macrophages in the spleen and other tissues phagocytose these immune complexes. But if you have if you have too many immune complexes due to some underlying processes, then macrophages might not be able to clear those immune complexes, and you might get an unwanted damaging immune response. So type 3 hypersensitivities could be here against microbial, against safe entities which are non-self. They can be here. They can be part of an autoimmune process, or they can be part of an immune response against an infectious agent. So we have three groups of type 3 hypersensitivities. Let's start from the first one, type 3 hypersensitivity against foreign harmless antigens. Well, the person that you're seeing in here is the person is a scientist who won the first Nobel Prize in medicine or physiology in 1901. He was a German physician named Emil Adolf von Behring, and he won the Nobel Prize because he developed an anti-serum for diphtheria. So diphtheria is a very serious infectious disease, which is associated with severe inflammation and swelling in the basically throat. So it's kind of pharyngitis, but much more severe than bacterial pharyngitis that I showed you in previous slides. So it's caused by a bacterium named Corynebacterium, and Corynebacterium invades the pharyngeal area, and it generates this leather-like exudates in here. So the swelling due to inflammation is so severe that some kids that get diphtheria might choke. And even if they don't get choked, the toxins released by the bacterium can go and affect internal bodies, including the heart. The toxin that is derived from Corynebacterium diphtheria is cardiotoxic, so it damages the heart. So what Behring did was he produced an anti-serum for diphtheria. What is an anti-serum? It's a serum which contains antitoxins, Antitoxins are, well, it was later discovered that these are antibody molecules that can bind to the toxins and they can neutralize toxins. How did he generate that? Well, if you want to produce anti-serum for diphtheria, or maybe later for other types of toxins, the same thing was done for tetanus toxin, the same process of production of antitoxins or anti-serums was later adopted to generate anti-serums for venoms from snakes or spiders or scorpions. So these are all examples of anti-serums. The way that it was being produced was by injecting horses with tiny bits of the toxin. So in the case of what Behring did, he cultured diphtheria, Corynebacterium diphtheria. He cultured the bacteria causing diphtheria. He isolated the soup from those bacterial cultures which contained the poison, contained the toxin. He diluted the toxin and injected horses with them a couple of times, and then he collected serum from them. Why did he use horses? Well, because horses were considered strong animals, and they have a lot of blood, so you can easily collect from horses without killing them. So that's why horses were used for the production of anti-serums. So you're seeing in here that the person is basically injecting the toxin, and then maybe after a couple of weeks, they're collecting blood, and the serum part of the blood, after blood gets clotted, is collected and used as anti-serum. So this was the way that anti-serum was produced. And Behring used it to treat diphtheria cases, and he was very successful. But there was one side effect of this so-called serum treatment or serum therapy. Some of the kids that were receiving it started to developing rashes all over their body, skin rashes, after using the serum, after using the serum for the treatment of diphtheria. And this phenomenon happened later when people developed and used anti-sera for other types of toxins like tetanus toxin, or anti-sera for snake bites or scorpion stings. The same thing happened. Skin rashes happened all over the body with some other symptoms. And when people investigated the process, they recognized that these so-called skin rashes, these skin rashes that were basically a part of what is called serum sickness, was because the horse serum contained a lot of horse proteins. So it contained antibodies, horse antibodies against the toxin. So that was the good part. But it also contained a lot of horse proteins. And those horse proteins were considered non-safe by our immune system. And our immune system was starting to produce a lot of antibodies against those horse proteins. So these antibodies would go and bind the horse proteins, and they would form a lot of antigen antibody complexes. So at such a high level that it could not be cleared out by our macrophages. And those antigen antibody complexes, some of them would go and precipitate in blood vessels in the skin, and they will cause a sort of inflammation, which was presenting itself like these skin rashes. So that was due to basically so-called serum therapy. But sometimes a similar phenomenon was happening in a more localized form after using vaccines. So you know that tetanus is caused by Clostridium tetani. It produces a toxin. So if a person gets tetanus, one part of the treatment is to give them the antitoxin, anti-serum, which contains antibodies against the toxin, which if the anti-serum is produced in horse, it can lead to systemic basically skin rashes, which were basically serum sickness. But in some cases, people were getting the skin rashes in the area of the injection of the tetanus vaccine. So this is a different story. In this case, you're not doing serum therapy. You're injecting them with the toxoid, or the altered form of the toxin, so that their own immune system can produce antibodies. Basically, what we are seeing in here is passive immunotherapy. It's passive immunotherapy. Antibodies are produced somewhere else. And immunotherapy, which is passive, is usually basically it's usually it usually has therapeutic applications after the person has got diphtheria or tetanus or maybe a snake bite or a scorpion sting or a spider bite. You will give them the anti-serum to treat them. But in the case of vaccination, it's a preventive measure. It's a preventive measure, and it's an example of active immunotherapy. So the person's own immune system gets activated. So why this happens? Well, because tetanus vaccination usually takes place every 10 years. And sometimes when you get the tetanus vaccination, especially as an adult, you might have antibodies from previous time of vaccination still present in your blood. So you inject the person with the antigen, which is an altered form of the toxin, a harmless form of the toxin named toxoid. but the antibodies are still present from previous time of vaccination. So those previously existent antibodies will go and bind the antigen that you have injected the person with, and they generate a lot of immune complexes which are basically deposited in the skin, and they cause an inflammation there. So it's called Artus reaction after the name of scientist who discovered this. So in this case, we can say that we have type 3 reactions against harmless antigens. Sometimes it's systemic all over the body when you perform serum therapy. And by the way, serum, if it's basically serum containing antitoxins, for example, it's usually given through an intravenous route. So it spreads all over the body. But it can also be a local in the case of tetanus vaccination. It's called Artus reaction. So both of these are examples of type 3 hypersensitivity against harmless antigens. Systemic immune complex formation after IV injection of antiserums, or a local immune complex formation after injection of vaccines. Can we have type 3 hypersensitivity against the microbe? Well, again, microbes will require sufficient levels of immune response against them, but if the immune response gets too strong, or if the immune response gets basically targets like our own tissues, it can qualify as an unwanted damaging immune response. Can this happen? Well, yes. Again, going back to streptococci, in previous slides, in the case of acute rheumatic fever, I showed you streptococcal infection of the throat, the streptococcal pharyngitis, and it had an unwanted side effect that was a type 2 hypersensitivity named acute rheumatic fever. And acute rheumatic fever was because antibodies would go and bind to heart antigens, causing inflammation in the heart. We can also have skin infections by streptococci. It's called impetigo. And in case of impetigo, again, antibodies would be produced against streptococcal antigens. But in the case of impetigo, those antibodies are more likely to bind to streptococcal antigens which are present in the blood, because even though it's a skin infection, you might have streptococcal antigens present in the blood. The immune complexes might form, and those immune complexes might go to hit the glomeruli and get deposited there. So antigen antibody complexes being generated in the blood, and then when they enter glomeruli, they get stuck there. The other possibility is sometimes streptococcal antigens go to the glomeruli by themselves and they get stuck there. And then antibodies follow them and immune complexes are formed inside. So we have two scenarios: immune complex formation in the blood, and those immune complexes, because they cannot be cleared by macrophages at sufficient levels, they go to the glomeruli, and there you have a structure that traps big protein molecules. So antigen antibody molecules will be trapped there. And in some other cases, streptococcal antigens will get trapped in the glomeruli first, and then antibodies will go and bind them. In either cases, we have a lot of immune complexes here. And when you have immune complexes, well, neutrophils and some basically local macrophages will try to perform phagocytosis. But because they are stuck there, they cannot perform an efficient removal of the antigen-antibody complex. So they release the toxic granules that they have inside them, and it will lead to inflammation in glomeruli. It's called glomerulonephritis. And because it's happened after a streptococcal infection and it happens relatively fast, it's called post-streptococcal glomerulonephritis, or PSGN, post-streptococcal glomerulonephritis. So it's a very long term. In classes, I usually ask students to repeat it 3 times to see if someone can say post-streptococcal glomerulonephritis 3 times. So it's something that you can practice now if you're sitting in your dormitory or at home. Post-streptococcal glomerulonephritis is an example of type 3 hypersensitivity. It's caused by immune complex formation, and it's against the pathogen. All right. Can it be part of autoimmune disease? Can we have type 3 hypersensitivity, which is part of an autoimmune disease? Yes. We have a very famous autoimmune disease named SLE, standing for systemic lupus erythematosus. And in SLE, we have antibodies produced against antigens inside the cell's nuclei. They are called anti-nuclear antibodies. And anti-nuclear antibodies, well, when the nuclei are nuclei are inside intact cells. Antibodies cannot go inside and bind to them. But we have a lot of cells dying every day or every moment in our body, and the contents of their nuclei might be released to the blood. So if we have antibodies against nuclear antigens, they can bind to those antigens, and then they form antigen antibody complexes. And again, these antigen antibody complexes can be deposited in different tissues in the body. One of the tissues that antigen antibody complexes in SLE get deposited to are kidneys. So we have what is called lupus nephritis. Lupus nephritis. Sometimes they can be deposited in the skin. So you have a particular type of rash in the skin. Sometimes they can be deposited in other tissues. And in all of these cases, they can lead to inflammation. And because it can be everywhere in the body, it's called a systemic disease. It's called a systemic disease. All right, I didn't give you a break because we're close to the end of the class. So type 4 hypersensitivity, unlike the previous hypersensitivities, which were caused by antibodies, these are called by T cells. These are caused by T cells. And for this reason, these are called cell-mediated hypersensitivity. These this type of hypersensitivity could be present in here against safe non-self antigens. It can be part of an autoimmune process, or it can be part of an infectious disease. So let's see type 4 hypersensitivity against foreign harmless antigens. So this is a disease named celiac disease. So celiac disease usually happens in kids, but it can also happen in adults. And it's due to generation of immune response against gluten. Gluten is a protein which is part of the wheat, WHEAT, wheat that we eat, the wheat that we make bread from. So most of us, we eat bread from basically when we've been a toddler, we've been eating bread all through our life, and it's completely safe and we have no problem. Some people are sensitive to the protein component of the wheat flour, the gluten part of it, and they develop a disease named celiac disease. This is usually a kid that has chronic diarrhea, weight loss, and failure to thrive. So they don't grow very well. And if you look at basically, if you perform colonoscopy and take a biopsy and look at the intestinal epithelium under a microscope, in a normal epithelium, you have this villi, which are very important in increasing the absorption surface. So this is a normal intestinal epithelium. But in celiac disease, you don't see these villi. These villi are gone. And actually, if you can look at it, if you can look at it in a higher magnification, you will see that there are a lot of cells in here, which are mostly lymphocytes, like a collection of cells you see in here. These are lymphocytes, and they have infiltrated, they have entered the mucosa and submucosal layer. And the presence of those lymphocytes and the inflammation that they are causing is the reason for the loss of the villi. And it leads to what is called celiac disease. It's a malabsorption process. The body cannot absorb uh, different nutrients and even water sufficiently, and it will lead to chronic diarrhea. It's an example of a T cell mediated hypersensitivity against the foreign harmless antigens. Our lymphocytes, our T lymphocytes in this case, become active against the harmless entity, which is gluten. So it's a type 4 hypersensitivity, which basically targets the gastrointestinal system. Another example of type 4 hypersensitivity is what is called contact dermatitis. Contact dermatitis. So sometimes people who wear earrings, or maybe basically they wear other types of nickel containing bracelets, they develop what is called dermatitis, contact dermatitis. So earrings and other type of jewelry, they have gold in them, but they also have other metals. So these metals, things like nickel or even copper, some of the times they are foreign harmless entities, so they don't pose any risk for our body. But the tiny bit of those metals, sometimes they get absorbed to the skin and they change the shape of some self antigens that we have. And then T cells think that these are dangerous things, so they attack them. They attack them and they cause inflammation. It's called contact dermatitis. Contact dermatitis. And some people, by the way, separate contact dermatitis to two types: allergic contact dermatitis and irritant contact dermatitis, ACD and ICD. So this is allergic contact dermatitis. Even though the word allergy is usually used for type 1 hypersensitivity, but in this case, the word allergy is sometimes used. It's called ACD, or allergic contact dermatitis, which is a type 4 hypersensitivity. We also have ICD, which is irritant contact dermatitis, which is usually caused by detergents, the chemical agents which we use for like cleaning dishes or even washing clothes. That causes irritant contact dermatitis. But irritant contact dermatitis is not an immunological process. It's a chemical process. It's not an immunological process. Can we have type 4 hypersensitivity against microbes? Well, again, microbes, we require immune response against them. But if the immune response goes awry, if the immune response gets too strong or damages tissues, it can qualify as hypersensitivity. Yes, this is the chest x-ray from a patient with tuberculosis. You know, Mycobacterium tuberculosis causes an infectious disease named tuberculosis. It usually involves lung, and a lot of damage which happens in the lung, a lot of damage which happens in the lung is due to overactivation of T lymphocytes. So the T lymphocytes will go there to defend our body against, or our lungs against, Mycobacterium tuberculosis. But in a lot of cases, the T cell activation is too strong, so it damages the lung tissue. So the part which is against the bacteria, the part which is against the Mycobacterium tuberculosis, is the good part. But the part that damages our own tissues, or our own lungs, that's an unwanted damaging immune response. And it's basically, it qualifies as hypersensitivity. So it can be against the bacterium, but it can be too strong, damaging our tissues, and then it's a hypersensitivity. So we use this hypersensitivity reaction diagnostically. It's called the tuberculin test. So if you want to see whether a person has been exposed to Mycobacterium before, we get tiny bit of mycobacterial antigens and inject the person intradermally with that antigen. So if the person previously has previously developed T cells against mycobacterial antigens, those T cells will accumulate in here, and then they lead to some sort of hardness in the skin. We call it induration. And it's a skin test for tuberculosis. So I talked about a skin test in type 1 hypersensitivity, allergy skin test. This is another skin test, and there are differences in here. So in allergic reactions, it's an immediate hypersensitivity. It happens fast. So when you basically inject tiny bits of allergens in the skin prick test, you can read the response, which shows as little bumps and redness in half an hour. So it happens fast. But for the so-called tuberculin reaction, well, it doesn't happen so fast. You need to give them time. You need to give T cells time to accumulate. And usually it shows up after 48 to 72 hours. 48 to 72 hours. That is why that another name for type 4 hypersensitivity is delayed type hypersensitivity, or DTH. Delayed type hypersensitivity, or DTH. So to differentiate it from immediate hypersensitivity, which we see in the case of IgE-mediated reactions. And finally, can we have DTH, or type 4 hypersensitivity, against our own antigens? Yes. A lot of important autoimmune diseases are mediated by T cells, and they are examples of type 4 hypersensitivity. This is an example called rheumatoid arthritis. It's an autoimmune disease in which our own T lymphocytes will attack antigens inside joints, and they can cause arthritis. And after some time, they can lead to deformation in the joints, especially small joints of the hand. Do not mix up acute rheumatic fever with rheumatoid arthritis. These are entirely different diseases. Because of the presence of the name rheumato, some people mix them up. Acute rheumatic fever is a type 2 hypersensitivity, which is a side effect of a streptococcal infection, and it's mediated by antibodies. Rheumatoid arthritis is a type 4 hypersensitivity, which is mediated by T cells, and it's an example of an autoimmune disease. Acute rheumatic fever targets our own tissues, the heart tissues and joint tissues, but it's not a classical autoimmune disease. Another example of type 4 hypersensitivity, which causes damage to our own tissues, is multiple sclerosis. Multiple sclerosis is a disease of the central nervous system when we have damage to myelin. So if this is a nerve, we have myelin around that nerve. But if the myelin is attacked by T lymphocytes, it can lead to problem in the conduction of nerve signals, and it might lead to what is called multiple sclerosis. It's another example of type 4 hypersensitivity. Another example is type 1 diabetes. Insulin producing cells in Langerhans islands, they are called beta cells. So if beta cells are targeted by lymphocytes, in this example in here, the blue cells are the beta cells. If they are targeted by lymphocytes and they are destroyed, the person will be unable to produce sufficient levels of insulin, and the kid will. It usually happens in kids. It manifests in the first couple of decades of life. Develops what is called type 1 diabetes. This is another example of type 4 hypersensitivity. All right. So it's end of the class. I'm just going to show you a classification. The slide might be too small for you to see, but you can look at it in more, basically zoom in to see it easier later. So you can have type hypersensitivity in here. So it's only against non-self safe antigens. We don't have a type 1 hypersensitivity against autoantigens or against infectious agents, at least not discovered yet. So it can be food allergy, allergy to penicillin or other drugs, allergy to venom. We can have type 2 hypersensitivity in any of these three locations against foreign harmless entities like drug-induced hemolytic anemia, where the antibodies were targeting drugs that were absorbed to the surface of the RBCs, leading to blood cell lysis. Autoimmune hemolytic anemia, which is different from drug-induced hemolytic anemia, is a type 2 hypersensitivity, which is a type of autoimmune process. MG is myasthenia gravis. What is the example of type 2 hypersensitivity for infectious agents? Well, it's acute rheumatic fever, antibodies against streptococcal antigens targeting the heart. For type 3 hypersensitivity, we can have type 3 hypersensitivity against safe entities which are non-self. Serum therapy and serum sickness, especially serum if it's derived from animals like horses, is an example of type 3 hypersensitivity against safe entities which are non-self. We can have type 3 hypersensitivity as a part of an autoimmune disease. SLE qualifies as type 3 hypersensitivity autoimmune disease. And here we have type 3 hypersensitivity against infectious agents, post-streptococcal glomerulonephritis. And finally, type 4 hypersensitivity. So against safe non-self entities, it can be celiac disease against gluten, which is part of the wheat flour, or contact dermatitis. We can have type 4 hypersensitivity, which is an autoimmune disease like rheumatoid arthritis, multiple sclerosis, or type 1 diabetes. Type 4 hypersensitivity can also occur against infectious agents, which and the best example for it is tuberculosis. So this is basically the end of this class. You can feel safe now and happy now. So if you read the slides, especially this final slide, I think the summary slide would be very helpful. It should be sufficient for the exam, but you always need to look at the textbook in order to learn better. So don't forget to read the chapter in the textbook. The textbook that we usually use is the summary of the Abul Abbas immunology book, or the immunology for medical students. All right, end of the class. So I don't know if you can ask questions. Well, you can type your questions in here, or you can send me an email. I will give you my email at the end of the class. Okay, so how will we access the files? Through Navid, send them by email. Okay, so the file, if you mean the slides, I will send them to Ms. Hushiar, who is Tom's representative in the Kish at campus. And for the video itself, you can come back to the same channel and look at it anytime you would like. So it's automatically saved. It's automatically saved. I will try to edit it later, cut it into smaller parts if you want to take a look, but the video will be in here. All right. So you can have half an hour break. It's 9:30 now. We will start the infectious disease immunology class at 10 o'clock. All right. Thank you very much.